reactions and blood transfusion. An allergic reaction or hypersensitivity is a manifestation of tissue injury that results from the interaction between an antigen and an antibody. These antigens and antibodies are specific, and it's more like a lock and key method. The antigen, on the surface of the antigen, a different antibody will attach to it. So it's specifically made for a specific antigen. What is an antigen? An antigen is a protein that's on a foreign object that stimulates the immune system to produce antibodies. This can be a virus, a bacteria, a toxin, anything that will trigger the immune response. An antibody, on the other hand, is a substance that is only produced after an exposure to an antigen. It can be naturally produced by one's own body, or it can be acquired through vaccines or from mother to child. Antibodies are proteins that recognize and bind to antigens. Antigens enter the body through skin contact, such as animal dander, poison plants like poison ivy, or latex. It can come from an injection through medications or insect stings. It can come through ingestion, such as swallowing medications, or from nuts and shellfish. It may also enter the body through inhalation, such as through the inhalation of pollen or dust or animal dander. Normally, when antigens and antibodies interact, the antigen is destroyed and removed from the body or neutralized by different types of white blood cells. However, when an allergic reaction occurs, this is the pathophysiology. The antigen and antibody interact abnormally, and then primary and secondary chemical mediators are released. These chemical mediators produce allergic reactions in the body, whereby the second exposure can cause a severe or rapid response. The faster the reaction, the more severe it is. After previous exposure, special type of antibody, the immunoglobulin E, or IgE, is produced in the respiratory and intestinal tract. And these are areas where you begin to see most of the severe symptoms. Primary chemical mediators include histamine and prostaglandin. These are released by mast cells. They are the first chemical mediators that are released in the immune response. They also play a role in the inflammatory response. These chemical mediators are synthesized and stored in body tissues that were exposed to the environmental substance. Secondary chemical mediators include leukotrienes, bradykinin, and heparin. And these are instrumental in initiating an inflammatory response during a hypersensitivity reaction. So let's talk a little more about primary chemical mediators. We mentioned that the examples include histamine and prostaglandin. For these, you begin to see peak effects in about 5 to 10 minutes after an antigen makes contact with an antibody. So with histamine, you begin to see symptoms such as erythema or local edema, which will produce wheals and pruritus or itching. You'll also see a contraction of the bronchial smooth muscle, and this will produce symptoms such as wheezing and bronchial spasms. You'll see increased secretions, And that can cause rhinitis, which is a runny nose, watery eyes, and diarrhea. And also the primary chemical mediators will produce vasodilation. Secondary chemical mediators, as mentioned before, includes leukotrienes, bradykinin, and heparin. Leukotrienes can cause symptoms such as smooth muscle contractions, vascular permeability, which is manifested by mucus secretions in the airways. And secondary chemical mediators are generally 100 to 1,000 times more potent than histamine, which is a primary chemical mediator, in causing bronchospasms. Bradykinin can cause vasodilation and increased vascular permeability, edema, hypotension, and it can stimulate nerve cell fibers, which would manifest as pain in these clients. The secondary chemical mediator, bradykinin, also produces heparin. This is the same anticoagulant that we give to our clients to prevent DVTs. And it is produced by the mast cells. Types of allergic reaction. So in your textbook, Brunner's, it refers to type 1 overall as being anaphylactic with different levels of anaphylaxis. In other textbooks and in practice, you will find that the term anaphylaxis is only used for a severe reaction. The other reactions are referred to as mild and moderate type 1 systemic reaction. So in general, type 1 are the most severe types of allergic reactions. They have quick onset. It is a systemic response. For example, such as the case in asthma, allergic rhinitis, systemic anaphylaxis or reaction to insect stings, but it can also include local reactions. So a mild systemic reaction has its onset within the first 2 hours after exposure. The client will have peripheral tingling, a warm sensation, a fullness in mouth and throat, nasal congestion, periorbital swelling, pruritus, sneezing, tearing. So you might see some of that with seasonal allergies. A moderate systemic reaction, the onset is within the first 2 hours after exposure. The person may have flushing, warmth, anxiety, itching, plus the symptoms of a mild reaction. As it progresses or becomes more serious, they may have bronchospasm, edema of the airways or larynx with dyspnea, coughing, or wheezing. Then you have your severe systemic reaction. In this case, the onset is abrupt. The client will have the same symptoms as mild and moderate systemic reactions, but there's a rapid progression to the bronchospasm, laryngeal edema, and cyanosis. You want to be alert for dysphagia and hypotension. This is a medical emergency. Treatments. So the first line of treatment is prevention. That works for mild reaction, moderate, or severe type 1 allergic reaction. Meaning you want to avoid the allergens. Okay, you'd like to use HEPA filters, wear appropriate clothing. You want to use flooring instead of carpeting. Okay. The next treatment would be epinephrine, and that's used in all types of type 1 hypersensitivity reactions. it may be given sub-Q, IV, IM, or inhalation. It just depends on how severe the reaction is. Other medications that are used are antihistamines, such as diphenhydramine or Benadryl. Benadryl is considered a first-generation antihistamine. It may cause drowsiness. In mild and moderate cases, however, it may be substituted by a second-generation antihistamine. Examples of second-generation antihistamines include fexofenadine or Allegra, loratadine or Claritin, or sertrazine, Zyrtec. The biggest difference is that they're beneficial because they don't cause the drowsiness like the first generation antihistamines. These medications, all antihistamines, are considered H1 receptor antagonists. So they block the actions of histamines at the site that causes the allergic reaction symptoms. So just so that you know, when you hear the term when it's referring to a classification of medications, if you hear antagonist, that means that it blocks the action. If you hear the word agonist, agonist, that means it activates a receptor site. So other medications that are given during an allergic reaction are corticosteroids. Most often you'll see Solumedrol given. And the purpose of the corticosteroids is that it helps to prevent reoccurrence of the allergic reaction. It treats hives and angioedema, and it also decreases inflammation. And it may be given in different forms for mild, moderate, or severe hypersensitivity reactions. Additionally, albuterol is given, or some type of bronchodilator. And in severe cases, oxygen and normal saline are given. So in a severe reaction, epinephrine is generally given. Okay, remember, a severe reaction is what we know to be anaphylaxis. This is where the person's throat, they have trouble breathing, everything closes up. Okay, so epinephrine is given. It may be sub-Q, IM, and then given IV if necessary. Oxygen is given to keep the O2 sats above 90%. Nebulizers are given for the bronchodilation. And if necessary, intubation is performed. We're talking about a severe systemic reaction. Corticosteroids are given to decrease the inflammation. First-generation antihistamines are given to decrease the histamine effects. And then IV fluids, usually normal saline boluses, are given to treat the hypotension. And you want the systolic blood pressure to be above 90. And this is in a severe systemic reaction. Okay, so for desensitization, this is another treatment, and this is usually used in mild, moderate cases. And this is not a cure. It produces a state of clinical tolerance. So it's usually when for environmental reactions. So after skin testing is done to identify the environmental antigen, a small amount of allergen extracts, and it's diluted. It's given sub-Q or sublingually at weekly intervals. Sorry. The strength is gradually increased until a maintenance concentration is reached. Then periodic doses are given every 3 to 4 weeks over 3 to 5 years. Again, this is not a cure. So the sublingual tablets may be taken at home, but the sub-Q desensitization allergen must be given in a medical setting where emergency equipment is available. It's important to educate these clients about possible anaphylaxis, and emergency strategies must be provided. The FDA has only approved the sublingual tablets for those with allergic reactions to grass and short ragweed. It is not for food allergies such as peanuts. Type 2 allergic reaction is also referred to as cytotoxic allergic reaction. And so this is when the immune system mistakes a normal constituent of the body as foreign. And we see this with pernicious anemia, transfusion reactions, thrombocytopenia, hemolytic disease of a newborn, and conditions such as myasthenia gravis. Treatments include transfusions or plasmapheresis. And so with plasmapheresis, this is where the plasma is separated from the red blood cells, cleansed or exchanged with donor plasma. This is similar to dialysis, and it usually takes about 2 hours. It's also referred to as therapeutic plasma exchange. Type 3 of a hypersensitivity reaction occurs, it's also called an immune complex reaction. It occurs after an antigen-antibody complex is cleared from the circulation by white blood cells. They may be deposited into the tissues or vascular endothelium. And this results in tissue injury and vascular permeability. Instances of this include lupus and rheumatoid arthritis. And so you often, in these conditions, you often see a swelling of the joints. Treatments include antibiotics, anti-inflammatory agents, and analgesics. Our fourth type of allergic reaction is considered a delayed type. And this is where T lymphocytes are activated and inflammation causes tissue injury. So this type of reaction is also used for cell-mediated immunity, such as a TB test. And this is where you can check to see if the person currently has antibodies to or somehow have been exposed to a particular disease. So what do you want to teach these clients? You want to teach them to minimize exposure to allergens, and this might include environmental controls such as the use of HEPA filters in the home or avoiding certain foods. And then you want to teach them about medication instructions, such as the use of inhalers, the use of an EpiPen, limiting operation of machinery with some antihistamines, and other things such as rebound nasal congestion with the prolonged use of decongestants. For strategies to control allergic symptoms, that also goes under the umbrella of minimizing the exposure to allergens. And this might mean the use of medications such as antihistamines regularly, um, having short-haired animals as pets rather than animals that shed a lot of hair. As far as emergency treatments for severe allergic reactions, it's important to help the patient and their families identify the signs and symptoms of emergent allergic reactions before they become so severe, and teach them how to use an EpiPen, how to use rescue inhalers, how to wear the importance of wearing a medic alert bracelet. If a person has a history of severe allergies, it's not enough for them to carry Benadryl on their person at all times, but they should also have an EpiPen with them at all times. And then you also want to tell these clients to keep their follow-up appointments with their providers. And this provides long-term monitoring and maintenance. Your textbook, your Brenner textbook, offers a great reference in their plan of care for patient education. When you teach about the use of an EpiPen, you want to tell them to form a fist around the EpiPen, and there are different types of them, but generally you want them to form a fist around it, pull off the safety release, place the orange end hard into the outer thigh, a 90-degree angle, so that it clicks. And it's important for them to hold it for 10 seconds so that the medication is released into the thigh. So let's talk a bit about blood transfusions and the transfusions of blood products. So why do we give them? Indications include anemia. Okay, and I have listed there the normal hemoglobin and hematocrit values for males and females. It's also given for clotting disorders such as hemophilia or for INR regulation. Volume disorders, whole blood and albumin are often given if someone is hemorrhaging or if they have other fluid volume deficits, not corrected through fluids. If the person has an immunodeficiency, such as decrease in the white blood cells due to chemotherapy, if they have HIV or AIDS, if they have a drug reaction or decrease in the immunoglobulin, very often they may be given a transfusion. If they have burns, albumin is often given because of the decrease in plasma. Or simply if they have a low level of blood products, such as a low level of platelets or a low level of white blood cells. General symptoms that the person may need, other than the laboratory values, would be general symptoms that they would need a transfusion include tachycardia, chest pain, dizziness, lightheadedness, low blood pressure or hypotension, confusion, and shortness of breath. And I would refer you to your TRACE textbook, page 1490, for more information. When a blood product is prescribed, it's important to consider the condition of the patient. For example, you Might have a client who is anemic, but also has an underlying renal disease or congestive heart failure, and they can't tolerate large volumes of fluid because of the risk of circulatory overload or fluid volume excess. In these cases, the provider might order packed red blood cells instead of whole blood to minimize the amount of fluid the person is given and still treat the anemia. Your Brenner textbook outlines other blood products that are available for transfusion. Blood types. So a lot of this is a review from A&P for you, but the ABO system identifies which sugars are present on the membrane of an individual's red blood cells. AB positive people are called universal recipients, meaning they can get blood from anybody. And O negative people can donate blood to everyone. You can refer to the table in your TRACE textbook, page 1491, table 39-9 for more information. So when someone is going to get a blood transfusion or transfusion of blood products, very often the provider will order a type and cross match. And they'll also look at the RH factor. So the RH factor is the rhesus factor, and that's located on the surface of the red blood cells, along with the ABO antigen antibodies. So the type determines the person's blood type. The cross match determines the compatibility between blood specimens, the donor and the recipient. The RH factor is an inherited antigen in human blood. A person whose blood contains a D antigen is considered RH positive, whereas RH negative blood lacks a D antigen. An RH negative person will develop anti-RH agglutins, or antibodies, if they're given RH positive blood. And that happens the first time they receive it. Subsequent transfusion with RH positive blood will cause red blood cell hemolysis. And this is often seen in pregnant women. It's very important to test them as well, the blood type of the baby and the blood type of the mom, because of the mixing of the blood that occurs. Platelets, on the other hand, do not need to be typed. You don't need to know the ABO, simply because there are no antigens for the ABO antibodies to attach to on the platelets. Fresh frozen plasma, however, requires ABO compatibility, but you don't have to test for RH on fresh frozen plasma. So you're going to give blood to your client. These are steps that are necessary for the blood transfusion or the transfusion of blood products in order to do it safely. So before the procedure, it's important to have a signed consent. It is the physician's responsibility to get the signature on the consent. You may be called as a witness to witness the consent, or you can also explain the information further after the physician or provider has done it initially. You need a physician's order. It must specifically say transfuse. Okay, so sometimes you may get an order that says type and cross 2 units of packed red blood cells. That didn't tell you to transfuse it. If you transfused it without the order, you're giving it on your own. So it must say type and cross, and it must say transfuse. You need an order for a type and cross match. You need to use the two identifiers to verify who the client is. When you receive the blood, you need to check for the expiration date of the unit. You need to examine the blood product. You want to check for clot. You want to check for leakage. You want to check for color changes. And you want to check for bubbles. If you see bubbles in a unit of blood or blood product, that means that there's bacterial growth. You also want to make sure your patient has a patent IV access. Now, generally, you want to do this before you even send down for the blood, because blood can only be like hanging around unrefrigerated for a short time. And the refrigerators that we have on the units are not adequate to store blood. So the blood must remain in the blood bank until you're ready to give it. So for the access, you generally need a 20 gauge or larger for whole blood and packed red blood cells. Platelets and plasma may be given through a 22 gauge. But you always want to check the policy for your particular institution. Additionally, you want normal saline with filtered tubing. And the purpose of the filter on the tubing is to filter out fibrinous clots and platelet clumps that you might not see that might develop in the blood due to storage. So now we're ready to hang our blood or blood product. So in hanging blood, let's look at some of the steps that are necessary for safe blood product transfusion. All right, so you want to obtain baseline vital signs as well as a baseline assessment. This would be listening to the lungs, checking for edema, and this is so that you can monitor the patient closely and note any changes that would occur. You want to repeat the vital signs 15 minutes after the transfusion is initiated, and then every half hour or hour per agency requirements. The nurse should remain with the patient for the first 15 minutes. And this is because, in general, any reactions that would occur would be first seen within those 15 minutes. The transfusion should begin slowly at 5 milliliters per minute for the first 15 minutes. And you want to, generally in that 15 minutes, you should see 50 mLs that have been transfused. And that's enough to see a transfusion reaction. Remember, blood can only hang for 4 hours. Otherwise, there is a high risk of bacterial contamination. You want to educate your patient about transfusion reaction signs and symptoms, and I'll get more into this as we progress in this lecture. Post-procedure, you want to continue to assess for transfusion reactions, because sometimes it won't happen until after the blood has been transfused. You've taken the unit down, and it may not occur until after. So you want to continue to monitor the client. You want to dispose of the materials in a biohazard receptacle, and you want to document. So in order to accurately document, you want to include the type of blood product, the time it started, the size and site of the catheter, the indication or why was it given. You want to include pre, during, and post-procedure vital signs. Of course, that may be recorded in a different section of the chart. You also want to include the other assessments such as lung sounds. You want to document any complications such as the patient's reaction, if they had a reaction, or how they tolerated it. You want to document education given. You want to document the time completed. And you want to document how much was given in the I&Os. Let's go over the different types of transfusion reactions. The first type is febrile or non-hemolytic transfusion. It's also called pyrogenic, meaning they're going to have a fever. So with this, you're going to see chills, fever, headache, nausea, vomiting. It usually does not progress to severe anaphylaxis. But what's happening is the blood is compatible, but there are antibodies in the recipient's blood that are reacting to the donor blood. So what do? For a febrile, non-hemolytic transfusion, you want to stop the infusion. You want to keep the vein open with normal saline running through new tubing. You want to notify the provider right away, and you want to administer the antipyretics as ordered. Acute hemolytic transfusion reaction. This is when the blood is incompatible. There's going to be an immediate onset of fever, headache, sharp lumbar or flank pain, shaking, chills, nausea or vomiting, red or black urine, and it can progress to shock. Now, the reason for the back pain is that the kidneys are trying to get rid of this antibody-antigen complex. So they're being overloaded, trying to clear it from the system. So what do? You want to stop the transfusion. You want to keep the vein open with normal saline and new tubing. You want to notify the physician stat. You need to obtain blood samples from the site. You also need to obtain first voided urine and send it to the lab. You may need to treat shock if it's present. You need to send the unit, the tubing, and the filter to blood bank. And you need to draw a blood sample for serologic testing. So the issue may be that the blood was labeled wrong. You did everything correctly, but the blood was labeled incorrectly, and so now you have an acute hemolytic transfusion reaction. So let's talk about an allergic or hypersensitivity reaction to the blood. With this, you're going to see flushing, urticaria, wheezing, laryngeal edema, tightness in the chest. There may be mild or severe type 1 reaction. And then you may, if it's severe, you're going to hear stridor and lung sounds. When you hear stridor, that means that the trachea, the larynx and trachea are beginning to close. And you're starting to go into a medical emergency at that point. So what do? For an allergic reaction, you stop the transfusion, you keep the vein open with normal saline in new tubing, you notify the physician right away, you administer antihistamines like IM, IV, parenterally as ordered. Again, keeping in mind that it's not that the person is allergic to the blood itself. It has a wrong type. It's just they're having an allergic reaction to something in the blood, whether it's a chemical that's used to help prevent the clotting, for storage purposes, whether it's other antibodies or other antigens that is in the donor blood, but there's something that they're reacting to, not necessarily the blood itself. Our next type is circulatory overload or hypervolemic. And in this case, you would notice dyspnea, precordial pain, pain around the ribs, cyanosis, distended neck veins, a cough with pink tinged sputum or hemoptysis, and you begin to hear crackles in the lungs. So what do? You want to slow down or stop the infusion. So if it's mild, you can slow it down and give diuretics and oxygen, as ordered. If it's severe, you want to stop it. So because it's not an allergy, you want to flush the angiocatheter with normal saline, but you can keep that tubing. You want to monitor the vital signs. You want to check the jugular veins for distension. You want to check for dyspnea and continue listening to the lung sounds. Of course, you want to notify the physician right away. And you want to place that patient or that client in an upright position with their feet dependent. And that's going to facilitate the breathing. Our next type of transfusion reaction is a bacterial contamination of the blood. This client would present with fever, chills, vomiting, diarrhea, hypertension initially, then hypotension as the person goes into septic shock. So sometimes if you didn't check for the bubbles, remember I mentioned that the bubbles indicate some bacterial growth, or maybe it wasn't noticeable. So given your client who has this, what do? You stop the infusion. You keep the vein open with normal saline and new tubing. You notify the physician stat. Blood cultures would be ordered and you return the blood bag back to blood bank right away. Monitor vital signs. Generally, antibiotics would be ordered stat. You want to give those. And you also want to administer fluids. Disease acquisition. So this is generally going to be discovered probably in the longer term. You wouldn't really see it immediately per se. So although donors are screened and all blood is tested, there is still the possibility of disease transmission through the transfusion. For example, There's like a 1 in 350,000 chance that the person gets hepatitis B or C. There's like a 1 in 1.5 million chance that the person gets HIV or AIDS from a blood transfusion. They can also get CMV or cytomegalovirus. If they have, if they're severely immunocompromised, you might see things such as graft versus host disease. And usually for immunocompromised patients, in order to avoid these things, blood is irradiated for these patients. Some other diseases that can be acquired is Creutzfeldt-Jacobs disease, which is a type of human mad cow disease. And generally, people who have spent 5 years or more in Europe from 1980 to the present, in certain areas of Europe, they cannot donate blood, just so that this human mad cow disease is not transmitted to clients. This last type of transfusion reaction is transfusion-related acute lung injury, or TRALI. A transfusion-related acute lung injury is a potential complication that results from a transfusion of any blood product, but most commonly seen with plasma and platelet transfusions. So this transfusion reaction results in an acute lung injury within 2 to 6 hours of administration. And according to research, it is the most common cause of transfusion-related deaths. So it's believed to be caused by an antibody-antigen reaction between the donor and recipient plasma components, or by an activation of certain neutrophils due to an insult to the patient's vascular endothelium. The acute lung injury occurs when the neutrophils cause the alveoli of the lung to become edematous. Signs and symptoms include acute dyspnea, hypoxia, hypotension, and sometimes rarely hypertension, fever, and pulmonary edema, which is not caused by a cardiac issue. Treatment is aggressive, including oxygen therapy, intubation, and fluid support in order to prevent death. Corticosteroids don't help, and diuretics can make things worse. Blood banks should be notified in these instances so that other units from the same donation can be quarantined. Preventative strategies for those who have a personal history, who are at risk for this condition, or who have a family history of this condition include screening donors for these antibodies, limiting the frequency and amount of product in which these patients receive during a transfusion, and using plasma and platelets exclusively from males, because females who have been pregnant are more likely to have developed these antibodies. It's important to be aware of cultural preferences. So Jehovah's Witnesses refuse transfusions of blood and blood products. So be aware of that. Christian Scientists, generally the adults will refuse transfusions for themselves, but they may give consent for their children to be transfused. And sometimes some clients just have a personal preference. They may refuse a transfusion due to fear of contracting a disease. So as a nurse, how do you respond to this? It's important to be transparent and informative with your clients when they ask you questions about blood transfusion. So while there are pharmacological alternatives such as erythropoietin, which stimulates red blood cell production, there are no artificial blood alternatives available in the US. Additionally, for elective surgeries, individuals can donate their own blood a few days prior for use during surgery.